A single sedation mistake in the ICU can add weeks to your patient's hospital stay, cause permanent brain damage, or even kill them. Yet most nurses learn sedation management through trial and error on real patients. Hey everyone, it's Neil with NurseBrain, and today we're diving into something that could make or break your career as an ICU nurse, mastering sedation management. Now, I know what you're thinking. Sedation is just keeping patients sleepy so they don't pull out their tubes, right? That's exactly the kind of thinking that leads to the complications I see every single day. Here's what they don't tell you in nursing school. ICU sedation isn't about making patients sleepy. It's about walking a tight rope between life and death. Too little and your patient fights the ventilator, develops PTSD, or injures themselves. Too much sedation and you're looking at delirium, prolonged mechanical ventilation, ICU acquired weakness, and a mortality rate that jumps by 10% for every day of deep sedation. In the next 14 minutes, I'm going to teach you the 5 critical sedation principles that separate novice nurses from ICU experts. We'll cover the exact dosing protocols for every major sedation agent, the RASS assessment that 70% of nurses perform incorrectly, the sedation vacation protocol that can cut ICU stays in half, and the deadly sedation traps that I've seen claim too many patients over my years in critical care. I've been teaching critical care for over a decade. I've worked in level 1 trauma ICUs and I've seen what happens when sedation goes wrong. By the end of this video, you'll have systematic approach to sedation that will keep your patients safe and make the nurse that doctors trust with their sickest patients. But before we dive into the how, let me tell you about a patient that changed everything I thought I knew about sedation. I had a 45-year-old construction worker admitted with ARDS from pneumonia. Day 1, we kept him deeply sedated, RASS score -4, completely unresponsive. He is comfortable, we thought. Day 5, still deeply sedated. Day 10, we finally started lightening his sedation, and what we found was devastating. He had developed ICU acquired weakness so severe he couldn't lift his head. Delirium so bad he didn't recognize his wife. It took him 3 months to walk again. Here's what I learned. We don't sedate patients for their comfort. We sedate them for 6 specific life-saving reasons. First, to allow tolerance of painful procedures like intubation and central lines. Second, to optimize mechanical ventilation. Think permissive hypercapnia in ARDS patients. Third, to decrease oxygen consumption and septic shock. Fourth, to reduce intracranial pressure in brain injury. Fifth, to facilitate therapeutic hypothermia. And sixth, to prevent self-harm from agitation. But here's the critical part. Every single one of these has a specific endpoint. We're not sedating to unconsciousness. We're sedating to achieve a specific psychological goal while maintaining the lightest level possible. Now, here's where I see nurses make their biggest mistake. They think sedation assessment is subjective. He looks comfortable is not an assessment. I've watched nurses chart patient appears comfortable while their patient was actually in RASS -4 coma, accumulating sedation that would take days to clear. The Richmond Agitation Sedation Scale isn't just a number, it's a validated tool that predicts outcomes. Here's how you do it right. First, observe without stimulation. If they're moving, talking, or agitated, you're looking at RASS score 0 to +4. If they appear asleep, call their name loudly and tell them to open their eyes. Sustained eye contact and eye tracking, that's RASS -1. Brief eye contact under 10 seconds, RASS -2. Eye movement, but no eye contact, RASS -3. If there's no response to voice, provide physical stimulation. Shake their shoulder or rub their sternum. Any movement to physical touch is RASS -4. No response at all, that's RASS -5, and that patient is in coma. Patients maintained at RASS negative 2 or lighter have shorter ventilator days, shorter ICU stays, and better long-term outcomes. RASS negative 3 or deeper should be rare and reserved for specific indications like severe ARDS or elevated ICP. But knowing your target means nothing if you're using the wrong weapon to get there. Let me tell you about the medication revolution that's happening in the ICUs right now. For decades, we used Midazolam and lorazepam as our go-to sedatives. Then the research hit us like a truck. Benzodiazepines increased delirium by 20%, prolonged mechanical ventilation by an average of 2 to 3 days, and increased ICU mortality. Propofol, your precision instrument. Loading dose is 1 to 2 milligrams per kilogram IV push over 3 to 5 minutes. Maintenance infusion start at 5 to 10 micrograms per kilograms per minute, titrate by 5 to 10 micrograms per kilograms per minute every 5 to 10 minutes. Maximum dose 4 milligrams per kilogram per hour. Watch for Propofol infusion syndrome above this. Onset 30 seconds, duration 3 to 10 minutes after stopping. Perfect for procedure and short-term sedation. Dexmedetomidine or Precedex, your secret weapon. Loading dose 1 microgram per kilogram IV over 10 minutes. Optional, often skipped to avoid hypotension. Maintenance infusion 0.2 to 0.7 microgram per kilogram per hour. Titrate by 0.1 microgram per kilogram per hour every 30 minutes. Maximum dose 1 to 5 micrograms per kilogram per hour. No respiratory depression. Anti-delirium properties, easily arousable. Excellent for alcohol withdrawal and delirium. Midazolam, use sparingly. Loading dose 0.02 to 0.04 milligrams per kilograms IV push. Maintenance infusion 0.02 to 0.1 milligrams per kilograms per hour. Avoid continuous infusions longer than 48 hours due to accumulation, associated with increased delirium and prolonged ventilation. Fentanyl, your workhorse. Loading dose of 1 to 2 microgram per kilogram IV push. Maintenance infusion 0.7 to 10 micrograms per kilogram per hour. Onset 1 to 2 minutes. Duration 30 to 60 minutes. No histamine release. Predictable kinetics. Morphine when fentanyl isn't available. Loading dose 0.05 to 0.1 milligrams per kilograms IV push. Maintenance infusion 0.07 to 0.5 milligrams per kilogram per hour. Watch for histamine release in hypotension, longer duration than fentanyl. Now, I'm going to teach you a protocol that could literally cut your patient's ICU stay in half, but I guarantee half the nurses watching this have never done it properly. Spontaneous awakening trials or sedation vacations were first studied by Kress in 2000. The results were staggering. Patients who had daily sedation interruptions had 2.4 fewer ventilatory days and 3.5 fewer ICU days. Yet many ICUs still don't implement this consistently. Here's exactly how you do it. Every morning, assess for contraindications. You cannot do a sedation vacation if your patient has active seizures, alcohol withdrawal requiring sedation, agitation requiring immediate interventions, neuromuscular blockade, active myocardial ischemia, or elevated intracranial pressure. If none of these apply, stop all sedative infusions. Don't taper. Stop them completely. Then, watch and wait. You're looking for 1-4 endpoints. The patient becomes alert enough to follow commands. They become uncomfortable or agitated. They develop respiratory distress, or they show signs of pain. During the trial, monitor for failure criteria: agitation requiring intervention, respiratory rate over 35 or under 8, oxygen saturation below 88%, respiratory distress, acute cardiac arrhythmias, or signs of myocardial ischemia. If any of these occur, restart sedation at 50% of the previous dose. When restarting after failed sedation vacation, Propofol, restart at 50% of previous rate. Titrate up by 5 micrograms per kilograms per minute every 10 minutes. Dexmedetomidine, restart at 50% of previous rate. No loading dose needed. Fentanyl, Give 25 to 50 microgram bolus, then restart infusion at 50% of previous rate. Successful sedation vacation allow you to assess neurological function, perform spontaneous breathing trials, and identify patients ready for extubation. It's the difference between a 5-day ICU stay and a 15-day stay. But here's what keeps me up at night: the complications of sedation that can be worse than the original problem. Delirium affects up to 80% of mechanically ventilated patients, and it's not just confusion. It increases mortality by 10%, triples the risk of discharge to long-term care, and causes cognitive impairment that can last for years. I've seen families destroyed by delirium that could have been prevented. Use the CAMICU to assess every shift. Look for acute changes in mental status, in attention, altered level of consciousness, and disorganized thinking. Prevention is key. Maintain light sedation, provide day-night cycles, encourage family presence, and mobilize early. Physical dependence develops faster than you think, sometimes in as little as 48 hours of continuous sedation. Here's how to taper safely. Propofol withdrawal. Reduce by 10 to 25% every 8 to 12 hours. Monitor for rebound hypertension and tachycardia. Can usually discontinue without taper if used less than 24 hours. Dexmedetomidine withdrawal. Reduce by 0.1 micrograms per kilogram per hour every 8 to 12 hours. Watch for rebound hypertension. This can be severe. Consider clonidine 0.1 to 0.2 milligrams every 12 hours for rebound hypertension. Benzodiazepine withdrawal. Reduce by 25% every 8 hours for short-term use. Reduce by 10 to 25% daily for prolonged use, less than 7 days. Watch for seizures, tremors, and diaphoresis. May need phenobarbital for severe withdrawal. Deep sedation combined with neuromuscular blockage creates the perfect storm for muscle wasting. Patients can lose 1 to 2% of muscle mass per day. The result? Prolonged mechanical ventilation, difficulty weaning, and long-term disability. So, how do you put all of this together into a system that keeps your patients safe and gets them home faster? Every shift starts with assessment. What's my patient's RASS target based on their condition? Are they achieving the target? If not, why not? Always follow the pain first approach. Assess pain using CPOT for nonverbal patients. Treat pain adequately with fentanyl 25 to 100 microgram boluses, then add minimal sedation to achieve your RASS target. For RASS adjustments, too agitated, that's RASS positive 1 to positive 4. Increase sedation by 25 to 50% or add bolus doses. Too deep, RASS of -4 to -5. Decrease sedation by 25 to 50% or hold infusion. Target achieved. RASS -2 to 0. Maintain current doses. Perform daily sedation vacations unless contraindicated. Use the wake up and breathe protocol. Combine sedation vacations with spontaneous breathing trials for maximum benefit. Monitor for complications every shift. Screen for delirium with CAMICU. Watch for withdrawal signs. Assess for ICU acquired weakness and monitor hemodynamic stability. Document everything: RASS scores hourly, pain scores, sedation, interruptions attempts and results, delirium assessments, exact medication doses and titrations, and any complications. This isn't just paperwork, it's patient safety data. Let me bring this full circle with that construction worker I told you about. After 3 months of rehabilitation, he did walk again. He went back to work, but he also developed PTSD from this ICU experience. His family went through financial hardship and he lost muscle mass he'll never fully recover. That's why mastering ICU sedation isn't just about passing your orientation or impressing your preceptor. It's about understanding that every sedation decision you make ripples through a patient's entire life, their family's future, and the healthcare system as a whole. Today, we've covered the 6 specific reasons we sedate ICU patients, mastered the RASS score scale that predicts patient outcomes, learned the exact dosing protocols for every major sedation agent, implemented the sedation vacation protocol that cuts ICU stays in half, identified the deadly complications with specific management strategies, and created a systematic daily approach that keeps patients safe. You now have the knowledge to be the nurse that doctors trust with their sickest patients. You can be the nurse who prevents delirium, who gets patients off the ventilator faster, who sends people home to their families instead of long-term care facilities. But sedation is just one piece of the critical care puzzle. If you want to master the complete approach to mechanical ventilation, including weaning protocols, troubleshooting, ventilator alarms, and liberation strategies, click on the video appearing on your right screen right now, because the nurse who understands both sedation and ventilation management is the nurse who saves lives. Make sure you subscribe and hit that notification bell, because we're building a community of nurses who refuse to accept "that's how we've always done it" as an answer. We're the nurses who demand evidence-based practice and patient-centered care. Remember, in the ICU, you're not just managing sedation, you're holding someone's life in your hands. Make sure you're worthy of that trust. Once again, this is NurseBrain, inspiring greatness one lesson at a time.